It was of interest to me many years ago when I was beginning this work to try to understand why there were differences in outcome of the same disease, acute lymphoblastic leukemia, in children versus young adults versus older adults. And one of the things that we thought to do with a pediatric colleague of mine at the University of Chicago using the cooperative group mechanism was to compare outcomes of a similarly treated group of patients by both pediatricians and adult clinicians, and that's the group between ages 16 and 21 years.
Can you actually define a group like that as being totally different from the older adults?
We can now. It wasn't so clear back then, but that was the one group that was overlapping, and the treatment approaches were slightly different by the adult groups compared to the pediatricians, even though many of the adult regimens, including the ones that we had used, were developed from pediatric regimens, but they diverged over the years. And so the one thing we thought to do was, let's look to see if outcomes in a similar age group of patients were identical if a pediatric regimen was used for those patients given by pediatricians versus an adult group regimen given by adult hematologist oncologists.
So could you say what you did, what the protocol was for this study?
It was a retrospective analysis of about a decade and a half of clinical trials performed by the Cancer and Leukemia Group B, which is the adult cooperative group with which I'm affiliated, compared to the Children's Oncology Group, or CCG, combination group at that time, which is the Children's Cooperative Group in the United States. So those were there were a series of trials performed by each of those groups, and we looked at the outcomes of 16 to 21-year-olds.
Now, you would have had a more intense regimen as compared with adult regimens, wouldn't you, perhaps? And also more consolidation, perhaps?
Well, you know, the differences are actually, we call them intensive pediatric regimens. Our adult regimens were also very intensive, but they were intensive in different ways. And the drugs that the pediatricians have always intensified were different from the ones that we've intensified. And so therein lies part of the treatment, the major part of the treatment difference.
Of course, I want to ask you about the benefits, but first I do want to ask you about toxicity, because the big risk is you could end up with too much toxicity.
Yes, so part of the reason I think that these regimens evolved in the adult cooperative group away from the pediatricians was in part, I think, just because of the fact that we believed that dose intensification of drugs that cause bone marrow suppression, called myelosuppressive drugs, would be important for both ALL as well as in AML. And because we sort of had used that approach in AML, we decided, I think, to use that approach in ALL as well, whereas the pediatricians have focused on another series of drugs that are an important component of ALL regimens, and those are drugs that include glucocorticoids, vincristine, and asparaginase. These are not such myelosuppressive drugs, but they're very intensive drugs for the treatment of ALL.
In your group of young adults and adolescents, did you get a high toxicity?
Well, are you talking now about the retrospective?
The retrospective study, yes.
Yeah, the toxicity profiles are very different, and there was quite a bit of toxicity in both, but the treatment-related outcomes, toxicities, were different but not dramatically so for that same age range of patients. But the outcomes were dramatically different, and so dramatic that it caused a big uproar when I first found those data. I didn't actually believe them myself when I first saw them. This is a long time ago now. But there was a 30% difference more than 30% difference in survival, event-free survival, if you were a 16 to 20-year-old treated on a children's regimen versus an adult regimen. Okay, and that's why we've moved forward.
So what were the outcomes of you've been looking then at 318 patients of whom...
Now, that's a different story. So now
okay, so
we
tell
took
me about the study.
Okay, so the study is a prospective study of actually 296 eligible patients treated by the United States cooperative groups. And they were between ages 16 to up to the age of 40, and with both precursor B and precursor T ALL. And we took the pediatric regimen that was most recently used for high-risk pediatric ALL by our colleagues in the Children's Oncology Group, and we applied that identical regimen to this population of patients.
Primary endpoint was what?
The primary endpoint was actually feasibility, tolerability, and event-free survival.
What did you get?
We got the fact that we showed that it was feasible, it was tolerable, that our treatment-related mortality was not different than a similarly aged population treated on the Children's Oncology Group trials. There were some subtle differences in toxicity, particularly during the first month of treatment, that we still need to tease out. But the important point is that we were able to accomplish this regimen, that we had low treatment-related mortality, and that our event-free survival at 2 years, which is still quite early, has improved from our historical control, which was longer follow-up, admittedly, of 34% to now 66%, with 79% overall survival, with nearly 3 years of follow-up now.
Sounds quite good. What do you conclude from this?
I think that what we conclude is that we're not the only ones to have shown this. We're the largest study to have shown this. Other smaller studies have been done both in Europe and in the United States that have demonstrated that the use of a pediatric regimen is possible by adult hematologists for young adult patients with acute lymphoblastic leukemia, that it seems to improve outcome, and our conclusion is that we're going to use this regimen or a very similar regimen as the foundation for building future studies.
But you've been saying that not all patients are the same. There may be a worse prognosis group among these, and you can molecularly identify them.
That's correct, and we can identify them in a number of ways. Two of the ways that we've looked at is that recently a number of groups in the world have described a BCR-ABL-like signature, which basically is a gene expression profiling signature demonstrating upregulation of multiple kinases, many of which are targetable therapeutically. The other way to monitor these patients is by detection using molecular methods of minimal residual disease. And what we have found is that there are patients with this BCR-ABL-like signature who comprise almost a third of these patients who do poorly. Some of them have and others don't have. But another important prognostic marker is this minimal residual disease after induction therapy. So using both of those features, we are able to identify high-risk groups that we may be able to specifically target with particular therapies.
So what should doctors get out of all of this then? It sounds interesting.
I think it's a very promising result. I think the most important message that I would like to convey is that I feel it's critically important for this age group of patients to be enrolled on clinical trials in the United States. We're not as good in the adult groups at getting referrals for these patients to enroll on clinical trials, unlike the pediatricians who are generally all enrolled on clinical trials in the United States. And I think that that's the only way to make significant progress in survival. And so as we move forward now, I think we have multiple very exciting new agents that we can incorporate into the frontline treatment of young adults with ALL, but that we need to do this in a prospective, clinically trial-driven fashion.
You have some experience though, so what would you pass on to a doctor with a young patient with ALL in this category, young adults or
I think that this approach is reasonable. I think it needs, ALL is a difficult disease to treat. I think it needs to be treated by an experienced medical center group that has a lot of experience treating this disease. And I think that's one of the main reasons that ALL has improved so significantly in children in the United States, and perhaps one of the reasons that we've lagged behind. And we're very pleased and proud of our results that show that the United States Cooperative Group mechanism can work for improving outcome of young adults with ALL, but we need to do better. And one of the ways we'll do better more quickly is by enrolling more patients on new and important clinical trials.